Welcome to another edition of BR Ortho Talk. I'm your host, Matt Moscona. Glad to have you aboard with us here. And today we have the pleasure to be joined by Dr. Stephen Etheredge. Good to see you. How are you, sir?
Doing great. Great to be here.
I've really enjoyed being able to do this series. We've covered so much ground and so many different specialties and subspecialties with a lot of the physicians at Brock. One of the really interesting parts of the whole process, though, has been kind of getting to know the doctors as well. So you and I know each other a little bit personally, but for the person watching who maybe isn't as familiar, give me your Cliff's Notes backstory.
Sure.
Who are you?
Sure. So backstory is probably different than at least some of the other guys around here. Not from Louisiana, grew up in Florida, Fort Walton Beach, Destin area. Grew up over there, went to Florida State, which lately has been a little less popular. But I went to Florida State, played football there for 2 years as a running back at Florida State, and then kind of realized my career wasn't going to be in that. So I was there late 90s, actually played with Travis Minor, so a lot of guys here know him.
Sure.
But then from there, a little bit less traditional path to med school. I took a couple years off, went back home, managed a sports bar on the beach for a couple years, just made sure I was ready, kind of grew up a little bit. But then from there, went to med school. I'm not, like most of my partners, an orthopedic surgeon. My background's more in emergency and family medicine, and did a fellowship in sports medicine. So kind of ended up here with an opportunity to be one of the team doctors at LSU. I've been with LSU for, I think this is my 13th season now that I've been with LSU as a team physician, and that's kind of what opened the door to start working at Brock. And we've been here for a while. My family's here. We're enjoying it and just kind of loving life.
You left life on the beach, running a sports bar on the beach to go take care of injured people? What's the matter with you, man?
Yeah, I get asked that question a lot. I love the beach. I love back home, but just the opportunity was here was great. To work with LSU was something I couldn't pass up on. And then the people here have been fantastic. We've kind of really bought into the culture. My wife's from Texas. I'm from Florida. We ended up in the middle, but the people are what make it. Great people.
Was there a moment where you knew you wanted to be an orthopedist, or was that a path you thought maybe like as a young person, as a child, that maybe you thought you'd follow?
Sure. I think like a lot of people that do what I do, I played football. I was fortunate I had some injuries, nothing terrible, but I had my fair share of injuries, so I saw a lot of doctors. I always enjoyed science growing up. In fact, I've had a lot of my teachers tell me I should be a doctor or something like that. I had a guy that was my godfather who's a physician, one of my role models. So I think a combination of all the above just kind of fell into it. And I'd say, yeah, I probably always wanted to do definitely medicine. I think was one of my big passions, and then the sports side of it, which you get to do a lot of in orthopedics. And I think I also enjoyed, with the emergency medicine background, doing a little bit of everything. So I still do work occasionally in the ER. I still kind of see a little bit of everything out there, and I like that aspect of it as well.
So what's really interesting is, as I've learned, when a doctor decides they're going to go in orthopedics, and then they'll have to choose their subspecialty. So they'll go in all these different rotations to sort of figure out what I'm oversimplifying it, figure out what they want to do. Was that a similar process for you, where you had to go do all the different rotations and then you landed on sports medicine?
Yeah, absolutely. So, I had to go do all the same things they did. We do go through different rotations, starting off when you're in med school, then through residency, you kind of bounce around some. I think for me, part of the problem was I liked everything. So again, I enjoyed OB, I enjoyed family medicine, I enjoyed internal, I enjoyed surgery. I really thought I was going to go more into general surgery for a while, but then the sports side of it just kept coming back. I had the opportunity to mentor with a guy who was my team doctor, actually at Florida State, Dr. Chris Stowers, who was there for a long time, did a really good job, just retired. Definitely a guy that I looked up to and learned a lot from him. And because of that, I kind of more went that direction as I made my final decisions.
So give me a sort of a timeline. So you've said you've been at Brock now, or you've been the LSU team doctor for 13 years. Is that the timeline when you arrived at Brock as well?
So I initially was working full-time emergency medicine. Most of us that work at LSU, that's not a full-time job. It's a full-time job, but we have to have, a real job.
Sure.
So I was working more in the ER when I first got here. I've been at Brock almost 8 years now. So most of the time I've been here now has been at Brock, but the first few years I was doing more full-time emergency medicine and then the LSU part of it.
Mm-hmm. So how did the opportunity at Brock come about?
Well, the team docs with LSU, most of us are Brock physicians. Dr. Brent Bankston, Chip Bankston, Mark Field, Now we got Wayne Waggis back. We're getting some of the other guys more and more involved. So I was already working closely with them. We had talked about me coming to Brock right out of the gate. At that time, just timing wasn't right. The position wasn't quite there. For me, it wasn't the right call. And then after a few years, I think it just kind of came to be where there was a need at Brock, and I was able to do it. And so here we are.
What let's kind of talk a little bit about what your role is being an LSU team doc. I mean, I would think it would be so expansive considering you're talking 85 scholarship players, 120 on the roster in total, if my number's right. It feels like a massive undertaking that covers this massive scale.
It's big. So, with each of us that works with LSU, there's different roles. My role, so my official title, I'm the head team physician for LSU athletics. So with that role, not only do I kind of do the basic day-to-day stuff, but I sit in a lot of meetings. Back during all the COVID craziness, I don't know how many meetings I sat in with the SEC, with LSU, with NCAA, going over protocols, what's changing, what's different. So not only the orthopedic side of it, but, when they had all the concern about heart issues and was there a concern with that? Do we have to be worried about that? With concussions, we handle a lot of the concussion management. And then just down to their basic coughs, colds, sports physicals, everything that we have to do. I sort of kind of help oversee that, sit on those committees, and then the actual medicine side of it as well.
So you're everything from GP to orthopedist for 120 football players, but not just football, or
no.
Or
so
if you're an LSU team physician, it's all encompassing.
So we all kind of have sports we spend more time with. For me, football, baseball, gymnastics, spend a lot of time with those three. But we all help. We all cross over. We if somebody can't beat a basketball game, I'll cover some of the basketball. I'll see some of the players when they have injuries if I'm out there. So it's we all help each other out. So it works out pretty good.
You mentioned concussions. That is such a, if you'll forgive the phrase, like a hot button issue. And there's a lot of parents who don't want their kids to play football because of concussions. And I think we're just more educated, more aware of it. Let me just start with a big picture. When people ask you about concussions, specifically in football, what's sort of your launching point thesis?
So that is, to your point, a huge topic, a big topic today. With concussions, I think the first thing I always kind of talk about is, like so many things in the world, you have this pendulum that's swinging back and forth. And for the long time, when you were playing football, when I was playing football, the pendulum was way over here where we just basically ignored them, didn't understand them. Sometimes I feel like the pendulum maybe swung back a little too far because people do panic. It's a very serious condition. I don't mean to take it lightly. We understand now that the worst thing you can do is ignore them. But they're going to happen. A concussion is a brain injury that we take very seriously. But we also know that people recover from them, generally speaking. If you look just at general life, you're going to get concussions. I've had patients that I've seen who are maybe athletes, but they got a concussion bending down to pick up their cat and they hit their head on the doorknob, or walking into a pole when they weren't paying attention. You get in car accidents, you fall off your bike. These things are also cause concussions, and then beyond that, if you're worried about football, what's the thing that a lot of the parents do? Well, let's put my kid in soccer. Well, if you look at the NCAA statistics, the numbers aren't that different for incidents of concussion from soccer and football, especially with women's soccer, where they have almost the same incidence as football in a year-to-year basis. So, I like football, so I'm biased. I played football. I have a son. He's actually here watching us today, but people have asked me, can he play football? And he does. He plays football. I'm okay with it. But we also know that some people, we got to treat more carefully. And if you've had concussions, we've got to take a closer look at you. That's a big part of our incoming physicals when people get to LSU is, have you had concussions? How many have you had? How bad were they? And unfortunately, sometimes we've had to even disqualify athletes, even some really good athletes, because they've had too much trauma to their head. And that's always a tough thing to go down.
Let me go back for a minute. I want to come back to soccer. That's interesting. But if I could, let's start with a very basic question of what is a concussion? Define that for me.
Sure. So concussions, I think there's a bunch of definitions out there. But basically, it's a subset of mild traumatic brain injury. It is something that affects the function of the brain. It usually does not cause any structural damage, though. So the first thing with concussions, when I see someone on the sideline, is it a concussion? And really what I'm more worried about, is it something more? So that's what I'm concerned about. Do they have maybe an internal bleed or something like that, which fortunately we see very, very infrequently. But that's our first concern. After that, once we say, okay, and again, I don't mean to pacify it, but when it's just a concussion, I feel good that it's not something more serious. Then we go down this pathway. And really what it is an inflammatory process. We've kind of figured that much out. It's related to inflammation in the brain. It does affect the function of the brain, but not so much the structure or morphology. So we do know that generally speaking, these people are going to get better. The treatment is usually just rest, recovery. We hold them out of sports. Sometimes for the student athletes, we hold them out of school for a few days because we talk about both cognitive and physical rest. So the cognitive side is classwork. And then as they get better, you slowly reintroduce things, just like you would if you hurt your knee. You know, you don't immediately go back to playing football after your ACL surgery. You have to rehab it. You have to recover. The brain's no different.
So then go to soccer. Football makes sense.
Mm-hmm.
You wear a helmet and you crash your head into things. You're going to have head injuries. Why is the instances of concussions in soccer high?
So soccer, you know, you think about it, obviously football is a big contact sport, but we also know the helmets do offer some protection, of course, and then changes in rules where, you know, we're not leading with the head as much and things like that have helped for sure. With soccer, if you think about all the other, you know, unintended contact that still happens, you're going to run into somebody. You know, how many times are you diving for a ball and you take a knee to the head, an elbow to the head, you hit the turf and your head hits the ground. It doesn't necessarily have to be a collision with anyone. When you fall to the ground, if you hit the turf, you can get a concussion in any sport. So you get those instances. In rare occasions, even a ball to the head. I mean, if you take a square shot square to the head, I mean, if it's coming in hot, it'll give you a concussion.
I would imagine frequency matters because certainly you can recover from a concussion, but what most people I think are concerned with is a long-term prognosis. CTE, as we've learned, is a very real thing. Is there a magic number? I mean, is there a magic number in a certain frequency, like too many too often? Is it a total cumulative effect?
So it's really a little bit of all the above. You know, there may be certain organizations that may have a set number. We don't in the NCAA or at SEC or at LSU. But if anybody's had a 3, that's something that sometimes gets our attention. I know at the NFL Combine, any athlete that's had at least 3 concussions that comes in, we kind of ding them just to maybe look a little deeper. But I think the big picture is kind of more some of the other stuff you hinted at. How bad were the concussions? How frequently are you having them? How close together? How easily did you get them? You know, for example, if I have 2 guys, they both had 3 concussions when they got here. One of them, maybe he fell off his bike when he was 12. Maybe he got one playing, you know, middle school football and another in high school. None of them real serious. I'm not that worried about that guy. If I have another one who in the past 2 years had 3, maybe one of them he was out for 3 months with symptoms, that's much, much more concerning than even though they both had 3. So the number isn't quite as important as once you look at all those other variables. And that's what you look at. Did it take you a long time to recover? Were your symptoms really severe? Maybe you got the concussion really easily. Maybe you had 2 of them, and then the third one, you barely got a glancing blow and you had a really bad concussion. That's more concerning to me because it's like, gosh, you got that so easily. Your threshold is now much lower.
That's interesting. So I'm a fan of combat sports. I love MMA and boxing. And that's one thing you'll hear the phrase, guys will lose their chin, right? So the more that they fight, the more they get hit, the easier it is for them to maybe not get concussed, but to be knocked out. Or that's very clearly a real thing. I mean, that does happen. But is there anything that would illustrate or suggest why that's more common for some people than others? Why the effects might be more severe than others?
Yeah, and that's one of the things we're trying to figure out. You know, I think there is a lot of study. Obviously, like you said, this is a big topic, and I do think we know that if you've had more concussions, you are more likely to get more, and not just because maybe some of that's your style of play, maybe you play more aggressive, but some of it is also that there is an increased susceptibility. Kind of to your point, like their chin gets softer is what they use in boxing and MMA and things like that, and there's something real to that. There probably is some degree of restructuring the brain, probably kind of like, you know, if somebody who has a weak ankle, they've sprained their ankle a bunch of times. There's definitely something where maybe the brain loses some of its ability to recover and to take a lick and to kind of bounce back, so to speak. I think those are things we're still exploring. I know there may be some people smarter than me that probably have a better answer for the exact, you know, biology of that. but I think it's something that we've definitely come to recognize. And then now we have to kind of figure out, is there anything we can do to predict that? Outside of history right now, there's not. So, I mean, no scan that shows it. Unfortunately, it's really just taking a good history and understanding the patient.
What do you tell parents that are concerned about concussions and head injuries in sports? They said, Doc, what do I do? What do you tell them?
Well, I think first we respect it. I definitely respect that stance because I'm concerned about them. Like I said, my son plays football, but I'd be lying if I said I had no fear. It's something that happens. I think for one, so you have to make sure everybody understands it's a personal decision. I can't make anybody's decision for them. If a parent is really uncomfortable with their child, I'm not going to try and talk them out of it. I might give them some information, say, look, there's these other risk factors. If you think about it, everything you do in life carries risk. I think sometimes we try to be so risk averse that you almost don't live. And that's something I always take into consideration. But at the same time, I think you just have to tell them, look, there are risks. Generally speaking, it is exceedingly rare that we see major traumatic injury these days in football, and especially head injuries. You're more likely to have a spine injury or a cardiac event, really, than a catastrophic head injury, especially if we're smart with how we treat the athletes, meaning if they have a concussion, we treat it appropriately. If they've had multiple concussions, we take a closer look. I think it's just you got to go in prepared. We all have to accept that there are risks. That's the other piece of it that, unfortunately, I wish I could tell you, oh, yeah, your kid can play and never hurt his head, but it's part of sports.
What is some exciting, I'll use that term loosely, but is a lot of the advances in sports medicine that's also being used to help citizens in everyday life. We've talked a lot here about things like stem cells and PRP, but I've become most commonly aware of those things because of their use in sports and helping athletes heal. There was this might have been a decade ago, but USA Today did a feature on a pitcher who tore his UCL, which is commonly the Tommy John surgery, and they chose not to perform Tommy John, but instead just use stem cells to see if the ligament would regenerate and if this person could pitch again. And lo and behold, they did. Mm-hmm. So I think it's very exciting when you think about the prospects of things like stem cells. Where does stem cells fall on your radar and your use of them, belief in their efficacy, things like that?
Sure. So I do a lot of what we kind of consider regenerative medicine. That's a pretty big part of my practice as well, both at Brock as well as with the athletes at LSU. We've been very fortunate from the LSU standpoint. We've had a lot of support from the administration from day one. They've been very, very supportive since I've been here, at least, and I'm sure even before that. But with all the medical stuff, as long as we're safe, first and foremost. Obviously, they don't want us taking reckless chances. When I first got here, the director of all the sports medicine, Jack Marucci, really had a forward-thinking mind as well. I've had that benefit. And one of the things that we were always curious about is, can we be doing more with these, regenerative injections, or what are sometimes referred to as biologic injections? These would be things like stem cell injections, PRP, which is platelet-rich plasma. There's another one out there that we're doing a lot of now called A2M, which is alpha-2 macroglobulin. All these kind of fun, fancy things. And I think, without a doubt, we're discovering in medicine that there are applications for all of these things. I think it's also something where we have to be careful, because I do think there's a lot of misconceptions, and for example, the stem cells, there's this idea that, okay, we're going to put some stem cells into your knee and they're going to grow and attach to your joint and grow you new cartilage and all this stuff. And really, we haven't seen that. So then people get discouraged, like, well, then it doesn't work. And you're like, well, not exactly. What you're getting with a lot of these things, and this is why I use to my patients in the clinic, is you get what we kind of refer to as a paracrine effect. So, paracrine means it's a chemical message signal that stimulates your body to do things. And for example, with stem cells, inside them, you have a lot of these really powerful growth stimulators. There's what we call angiogenesis stimulators that encourage blood flow to an area to help promote healing, things that calm down inflammation naturally, some anti-inflammatory cytokines, and all these other things that are in there. And it's really that stimulation of your body that you're getting with a stem cell injection. Same thing with PRP, same thing with A2M. They each have their own kind of unique mechanism of action. I think that you have to, just like that pendulum I talked about with concussions, they work, And just like everything out there, you can read stuff and they say, oh, these things, they're going to change everything in medicine. Well, I don't believe that.
Okay.
I also believe they work. I think we got to find the right times to use them. And I think we've been very fortunate, like I said, with the support we have, that we've really honed it down to understanding when we can use them, when they work, when they don't. And then even then, we have to all go into it understanding it's not a guarantee. The downside to them right now, unfortunately, in the real world, insurance still doesn't cover these treatments. And you know, the funny thing I joke about with it is part of the reason is one of the upsides is they're ridiculously safe as long as you do them in the right locations. And that's why the FDA never really required these big studies in the beginning. So when we started doing PRP, like, oh, it's your own blood product. It's a safe product. So yeah, go ahead, go do that. We're not going to make you get all this approval. Well, the problem is there was never this huge study done again with controls and all that. We've seen them work. They do work, but there are things you can't fix with an injection. You know, if we have one of our athletes that has a rupture of their ACL, we're not going to go do a stem cell shot. It's not going to cure their ACL. They need to get it fixed. So I think understanding and expectations, but then once we go there, I mean, we've had some athletes that really have had miraculous results. I've had patients in the clinic likewise that of all ages, sizes, and shapes that have miraculous results. And then I've talked probably more patients out of it. You know, I have a patient that comes in with just end-stage arthritis. They're completely bone on bone in their knee. They think that a stem cell will go grow them a new knee, and it just won't. It might make it feel better for a very short time, but it's going to come back, you know? And so I think that's where we got to kind of figure it out with everybody.
Give me an example of a miraculous result.
So, you know, we had an athlete, a pitcher, who was having some shoulder issues, had pretty much been shut down for almost a full season or off season, and going into the year was not ready to go. Didn't really have a structural injury, so it wasn't like a big rotator cuff tear, but just had a lot of inflammation in his joint capsule. And this was one of the early times we were doing some of this stuff. And literally the athlete was scheduled to have surgery in the next few weeks just to go in and basically kind of one of these kind of clean out procedures in his shoulder because nothing had worked. He'd had cortisone injections. He'd had medication. He'd done physical therapy. He was working hard with his trainer. He was doing a lot of the right stuff. Well, we did one of these injections. We did the one that I referred to earlier, A2M, which is alpha-2 macroglobulin. It's one that comes from your own blood, similar to PRP. And, you know, I talked to his trainer. I was like, well, look, it's not going to hurt anything. I talked to the surgeon who was going to do the surgery, agreed, not going to hurt anything. Let's just try it. Because we'd had some good results with other things. We did the injection. Within a week, he had marked improvement in his range of motion. A lot of the stiffness that he had was being able to work out, which they had been working on for months. Within a few weeks, he was back doing bullpens and ended up pitching about half that season when we'd already kind of written him off for the year, thinking he's going to have surgery and be out. You know, and that's just one. We had another patient who, you know, regularly getting large effusions in his knee. No matter what we did, one of these guys, a lineman, big guy, had a knee that had already had a few surgeries, a lot of cartilage wear, and he just kept getting swelling in the knee. So one of those knees that we were always draining. We did one of these injections on him after we drained it. He played a whole season, didn't have his knee drained once, whereas he'd been getting it every few weeks. Finished the season in the best shape he'd been in probably in his whole career here, in part just because he was able to stay on the field. He wasn't doing anything different otherwise. So we've had a lot of them like that. Patients in my clinic who've dealt with just chronic tendinitis for years, and we'll do an injection for like a patellar tendinitis. You know, even some of my older patients that, you know, sometimes kind of given up on getting the condition better. Maybe they stopped running, maybe they stopped playing soccer, tennis, and we've gotten those patients back on the court on some level. And those are the ones that are rewarding because, you know, their life has changed. They enjoy their sport, they enjoy their hobby, and sometimes we can get them back to that, and we can do it in a pretty non-invasive, pretty rapid way.
So you gave us some miraculous results. You also mentioned there are times where if it's stem cells, PRP, A2N, where they don't work. What are some examples or instances where they don't?
Well, sometimes it's just bad luck. Sometimes a condition that I say you're the perfect candidate. You've got patellar tendinitis, and for example, when we've done some of these stem cell injections for patellar tendinitis, I find it's really effective, probably 80 or 90% effective. For some reason, there's a 10%, 20% subset that just don't get that same response, and I don't know why. And so we always have to go into it. I tell my patients, you've got to understand there's a small chance, even if it's something I feel really good about, that it might not work. And then there are other conditions that it's much less likely to work. If you have a really big tear of anything, you know, you mentioned the Tommy John injury, a UCL injury. more than likely, if it works, you have to have something left. If you have a complete full thickness tear, it's not going to mend that together. Same thing, I mentioned ACLs earlier. If you have really bad arthritis, if it's to the point that you have no space left in your joint, I really can't put anything in there with a needle that's going to fix your joint. It maybe make you feel a little better. I've had some patients that for whatever reason just couldn't do a surgery. Maybe they didn't have the time, maybe just with other medical conditions. So sometimes we'll try some of these things just to see, hey, maybe I can give you some temporary relief. But as long as we're all okay with that, you know, if your knee's shot, I'm not going to tell you that this stem cell is going to make you feel better the rest of your life. And if it does, it's probably because you don't live a lot longer. Just being honest, that's the reality, because they don't do permanent effects there. But if we're all okay with it, maybe it makes you feel good. But then there are conditions, soft tissue, tendonitis, maybe some of the early degenerative changes that we see in the joints. If you catch those earlier, you could probably do more good with those people.
I don't know how much you're able to disclose, but I'd love to know what the process is like at LSU. So maybe like if you don't use a athlete's name or something, but so let's use a hypothetical where if an athlete does have an injury, what is the process like toward healing? And the reason I'm asking, I'm curious how that might compare or contrast what you would do with someone in your clinic.
Sure. So there are some differences. Probably the biggest one is, you know, it's kind of funny. I use this example or this description for my patients all the time. You know, there's a real world and an ideal world. When we're talking about any treatment in medicine or really anything in life, you know, in the real world, we all have unlimited time, or in the ideal world, we all have unlimited time, unlimited funds, unlimited resources and access. Right. Most of us don't have anything near that. We have busy schedules. There are financial limitations, unfortunately. Can you get the treatment you need in a timely fashion? Well, at LSU, we do remove a lot of that. You know, it's part of how we make that work. So part of the world there is more ideal. We have athletes that we know their schedule. Sometimes we can even manipulate that schedule a little bit, understanding like, hey, you know, we can pull you out of this class or this meeting so that you can be there. We have physicians, we have trainers, we have massage therapists, chiropractors, all the above that go to LSU. Then when we have to do an evaluation, we have x-ray capabilities out there. We have ultrasound capabilities out there. If we need to get an MRI or a CT scan, we can fast track it. You know, we have a partnership now with Our Lady of the Lake, in addition to with Brock, to where between the two entities, we can get just about anything done almost immediately. So it makes it really nice. So with the athletes, if they have an injury, usually what happens is the athletic trainers are kind of the front line. They evaluate it. If it's something that they think might need to see one of us, either they let us know and we might come out there if I'm not already there. It might be a day, for example, I spend all day Wednesday on campus. So they might just have them come see me and say, hey, we're sending this guy over that just tweaked his whatever, hurt his knee last night in a game or whatever the situation is. Then usually one of us will evaluate them with their trainer. And then at that moment, depending on what we see, maybe we just go ahead and say, hey, this is a great candidate for this treatment. If I'm not sure, if I'm like, gosh, you know, I don't know if this is going to be the right thing, I might call one of my partners in. You know, I might call, you know, Dr. Bankston and say, hey, I just saw this guy. What do you think? This is what I'm thinking. On Sundays after football games, we have several of us there. We have an injury clinic. So like on this past Sunday, myself, Dr. Bankston, Dr. Field, Dr. Vincent Shaw, who works at the Baton Rouge General, we're all there with the trainers, with all these other people. So anything we saw, we'd sit there with the trainers and we'd say, okay, what do you think? If it's something complicated. And that's how we kind of handle it. And then, for example, if we think it needs an MRI, we set that up. If we think they might benefit from a stem cell injection, because we're very fortunate there, we keep a lot of those products on stocked at the facility. So, for example, for the stem cells, we keep them negative 80 degrees. We have a sub freezer literally at both big training rooms, football operations and Broussard, where I can literally go grab one right now. And if we're running low, they order us more. And if it's a blood product like a PRP, I can draw the blood right there. We'll spin it down. We have all the equipment we need. We do it right there. So we have a lot of benefits. That's how it works at LSU. You know, it's a big entity. The athletes, you know, I'm biased, but I really feel like the medical care we give is top of the line. I would really challenge anybody, even in the professional world, to counter that. If you look at what we do, I mean, there's a reason some of our former athletes come back for treatments here. Some of them don't. You know, there's great physicians, great trainers everywhere. You know, in the NFL, for example, I'm not talking bad about what they do, but I really think we do a top-notch job.
That is certainly an ideal world scenario. Sure. Just go grab a stem cell and fire crazy. Away. You know, one of the other things that I found interesting that you do is labeled ultrasound for same-day injections. What's the intention or the purpose of an ultrasound for an injection?
So with ultrasound, it's funny. For the longest time in medicine, I think the only application that most of us were familiar with was an OB.
Look at your baby.
Look at your baby.
There's a heartbeat.
And really, that was one of the main applications for it. There were other things, like in the vascular world, it's been used for a long time,
Sure.
for blood clots and things like that. In the past several years, ultrasound has really become a frontline tool in a lot of branches of medicine. In emergency medicine, we do it a lot, to help put in central lines. You can check the cardiac output almost immediately if you're worried about something there. But in sports medicine, we've learned, well, look, you can use ultrasound to look at muscles and tendons, and maybe it's not quite as sensitive as an MRI. It definitely doesn't penetrate as deeply into a joint. But if you're looking for superficial structures, it's really, really beneficial. So, for example, if you came in with a hamstring injury, I can immediately look at it with ultrasound if we thought we needed to. There are certain times with hamstring injuries we get scar tissue. You'll get other things that develop in those areas, or maybe you get a little pocket of fluid that we could go in and drain. I can find that with the ultrasound, and whether it's something I'm draining or injecting, I can then use the ultrasound to make sure my needle goes exactly to that location. So, for example, if you had a hamstring strain, I saw you had a little scar tissue, we can do a procedure called a hydrodissection. Go in with a needle, we kind of inject around that area with some numbing medicine, a little saline, try and break up the scarring. If you had a hip issue and you had hip arthritis, used to be we sent those to radiology because you really don't want to inject a hip joint in a clinic without guidance. Well, ultrasound guidance, I can put it right in your hip joint, because the problem is the hip joint, you have femoral artery, femoral nerve, femoral vein that are all right there. You don't want to inject the wrong thing. So I can make sure it goes where it needs to while avoiding, big structures like big arteries. So things we used to not be able to do in clinic, we now can. Plus, it's also grown where we're able to diagnose things more. We're able to do some of these other like hydrodissections, which is something we do with hamstrings, which, there's been several things with hamstring injuries that they're still bears, but between things like dry needling and now doing these hydrodissections, the biologics like the PRP and the stem cells, we're getting our hamstrings back way faster than we used to. Something that maybe was going to be 4 or 6 weeks, we sometimes get them back within a couple weeks, as long as it's obviously appropriate and safe.
By the way, these aren't just things that are necessarily for athletes at LSU. This is something that a golfer who's struggling to get on the course because his hip is bothering him, or a tennis player whose elbow hurts or something like that. You can help in clinic with stuff like this?
Absolutely. I had a patient today, and again, I won't divulge too much, but an older lady who came in who hurt her hamstring, just normal day-to-day stuff. It wasn't getting better. She kind of strained it, developed some tendonitis. She'd done therapy. She'd done everything else. We did a little hydrodissection. Now, I just did it today, so I'll be curious to see how she is in her follow-up. But the ones we have done in the past overwhelmingly have done good. We've done PRP for some of these chronic hamstrings that won't get better. I have these patients who are miserable, and I wish I could say it was 100%, but a really high percentage of them that, they've done everything else. They've done other treatments, medications. Maybe they even had a cortisone injection or something like that. Nothing worked. We did a PRP, and some of them do really well. It's not perfect, but it's a new option that's very safe that you can do same day. That the patients that get benefits, they love me. And I love that they love that. Again, it's life changing for them. It may not be a serious injury. It may not be something that's going to kill them. It may not be something that's dangerous, but it changes their life. You can't go play tennis anymore. You ride in a long car trip and you have horrible hamstring pain after the first 30 minutes, and you have to stop every hour to get out and stretch. Sometimes we're able to help that.
When you look ahead in a field that I would say it's safe to say, when you started practicing, were a lot of these regenerative medicines available?
Not a lot of them. When I first started, PRP had kind of just gotten in vogue. It was kind of being used a lot. And at that point, it was the Wild West because we had no idea what we had. And I think it disappointed a lot of people early on because we tried to use it for everything. And there were a lot of things that just, quite honestly, it didn't work for.
Like what?
They would use it for really bad arthritis, like I mentioned earlier, thinking, we can fix this knee with a PRP. Or they'd use it for a big, Achilles tear or hamstring, a big tear. And these people weren't responding. And we're like, well, gosh, it doesn't work, right? Well, but then if you kind of broke it down and figure out why it worked, why it didn't, let's kind of refine our skills. Let's refine when we're using these things. Let's maybe approach with a little bit more realistic expectations. I remember the first time I heard about it, even I was thinking, oh man, this is gonna be great. We're gonna fix the world with this, right? Well, no, but we're gonna fix some of it. And I think that's the thing I always try and also kind of tell my patients, you've got to have real expectations, because there are a lot of people out there, unfortunately, that just sell it, which not a true picture in my opinion. They because a lot of these things have become very big, and because some of them are very expensive, depending on where you go to have them done, people are making a lot of money and, in my opinion, taking advantage of their patients. And that's something that, coming at it from more of a true orthopedic standpoint, I work with guys that can fix your torn ACL. I'm not going to try and joke around and say, oh yeah, I can give you a shot that's going to fix. It's not. You need to probably get it fixed if that's the best option. And that's the part I think that I have the benefit of really working with a great group, that we have subspecialists in every department. We have guys that, I'm very lucky to work with, that I can still learn a lot from. So I think we're able to kind of balance it all out really well.
So if you look at just in your professional experience, this evolution of regenerative medicine, which is, you've been in it at a pretty awesome time to be in it. What excites you about what could be ahead, or what could be next, what's being worked on, the next evolution?
I do think there are aspects of it that we're going to find that we can do more. I do think that there are surgical conditions right now that might not necessarily be replaced, but significantly augmented by what we're doing. So I talked about stem cells, and that you can't just put a shot in your knee and it's going to go grow you everything you need. But maybe we can find ways to grow that structure before we put it in. Grow you a new meniscus. There's studies that are being done with things like that. Maybe we can't grow you a new ACL with a shot, but maybe we can put some kind of scaffolding in there to where we can go in, and if nothing else, maybe make that ACL recover faster. Maybe we can make the individual, because that's one of the problems in ACL injury, maybe we still have to have surgery, but maybe instead of it being an 8 to 12 month long recovery, maybe we shorten that down. Maybe we find new technology to make those things better, to make your recovery faster. Even now, for some of our post-op patients, if they're having a lot of swelling, for example, we've done some of these injections, and it's helped with their swelling, which helps them range of motion, which then helps them get better. It may not heal them. They still needed the surgery, but we help their recovery. And I do think we'll find more things and applications outside of orthopedics. You talk about type 1 diabetics. What happens is their pancreas has these beta cells that just basically die off and stop working. Maybe we can grow new beta cells that produce more insulin for those individuals. Things like that are on the horizon, I hope, that I think potentially are out there. It's going to take time. I don't know which ones we'll see in my life and which ones we won't, but I do think we'll see advances that do use regenerative and biologic medicine more. But I also don't think it's going to replace some of what we're doing now. I think there's certain, a lot of orthopedics, you talked to a lot of my partners on the surgical side, a lot of it's carpentry. And, the idea that I can fix a broken door by going in and just spraying some WD-40 on the hinges maybe ain't going to work if there's something wrong with the door frame. And that's a lot of what orthopedics is. Sometimes if the frame is messed up, there's nothing we can do other than go in and kind of do some carpentry on it. So again, you got to I have the benefit of seeing it from two vantage points. I like what I do. I love the future in regenerative medicine, but I think I'm also realistic. There's things that need a carpenter, that need something else. And we all have to understand that, I think.
I think what you do is more than just WD-40.
I appreciate it.
That's a fascinating subject matter, and we appreciate the time today.
For sure.